Good morning, everyone, or afternoon for those on the East Coast. I'm Laura Tobler, Program Director with the NCSL Health Program. On behalf of the National Conference of State Legislatures, I would like to welcome all of you to today's webinar, Substance Use Disorders and Mental Health, the Role of the States. We have a great slate of speakers today, and I'm very anxious to hear what they have to say. First, I'd like to give you a little introduction to NCSL before we get started. I want to remind participants that NCSL is a bipartisan membership organization of state legislatures. NCSL advocates for the interests of states and provides policymakers the opportunity to exchange ideas and network. This webinar is a platform for information exchange. We encourage a robust Q&A at the conclusion of the presentation and remind all listeners that opinions expressed on today's webinar do not necessarily represent NCSL's policy positions. Also, for those that would like to have a hard copy of the webinar slides, they will be available on the NCSL website as a video archive, and the link to that archive will be available at the end of the webinar on the resources page. NCSL staff has increasingly heard from policymakers and our constituents that investigating innovative ways to improve the efficiency of their state's behavioral health services is a very important topic for them. Our speakers today will share information on the current status of behavioral health services and highlight innovative and successful state programs. I have the privilege of introducing our three panelists today. Please advance the slide. We are very fortunate to have Maria Schiff as our first speaker. Maria Schiff directs Pew's State Healthcare Spending Project, an initiative of the Pew Charitable Trusts and the John D. and Catherine T. MacArthur Foundation to help policymakers understand state expenditures related to healthcare, and managing these costs while maintaining or improving Americans' health. Advanced slide, please. Our second speaker will be Kathy Brown. Kathy Brown is the Program Manager for Missouri HealthNet's Primary Care Health Home Initiative, which she has been with since January 2012 and has more than 20 years of healthcare management experience. Advance the slide, please. Our last speaker will be Barbara Cimaglio. Sorry, Barbara. You want to say how to pronounce your name?
Cimaglio, thank you.
Cimaglio. Oh, my mother, I'm Italian. My mother would be very upset with me. Barbara Cimaglio is the Deputy Commissioner for Alcohol and Drug Abuse Programs at the Vermont Department of Health, which she has been with since 2004. She is a nationally recognized leader in the field of alcohol and drug abuse prevention, treatment, and recovery. Next slide, please. Before I turn the floor over to Ms. Schiff, I would like to remind the audience that the webinar today will conclude with a question and answer session. Please note that you will not be identified when you ask a question, nor can other participants see what you have typed. As a reminder, you can submit a question at any time during the webinar by clicking on the control panel on the right side of your screen. Once you do so, enter your query in the questions box. We have left plenty of time for Q&A, so we encourage you to ask your questions. We will also post the PowerPoint presentation on the NCSL website, and the audio archive link will appear at the end of the slide presentation. The archive will be available in 5 to 10 business days. Now I would like to turn it over to Maria.
Thank you very much, Laura, and thank you to everybody for participating in this webinar. As Laura mentioned, the State Healthcare Spending Project is jointly sponsored by the Pew Charitable Trusts and the MacArthur Foundation. We've had 3 main project goals, which you can see listed on the slide. We've studied and reported on 50 state spending for all the healthcare programs listed above that states fund either partially or fully. Our last report to be released, which is expected later this year, will be about state retiree health insurance costs. Today I'll be talking about our most recent releases on the state's role in mental health and substance use disorders. All the data that I present in the next few minutes come from these reports that can be found on our website. The website's listed on my cover slide. Here's some quick statistics about mental health and substance use disorder. The statistic that jumped out at me is highlighted in red. That is the low treatment rate among those who have a substance use disorder. Many states, including the two we're about to hear from, have been making very strong efforts to increase access to treatment over the last couple of years because of a dramatic increase in drug overdose deaths across the country. A national SAMHSA survey found that the low substance use disorder treatment rate was due to many affected people not believing that they needed treatment, and many others who reported that when they wanted treatment, they either couldn't afford it or couldn't get into a program immediately. What I show here is a payer mix diagram for all U.S. healthcare spending in 2009. And coming onto the screen on the right is a similar diagram just for mental health and substance use disorder treatment and prevention. Spending for these two diseases is just a small fraction of what the U.S. spends on healthcare across all services, 7.4% in 2009 of total health expenditures. And the distribution of payers for mental health and SUDs is very different than for all healthcare. The biggest difference is the role that state and local money from a state's general fund plays in these treatments. In addition, Medicaid, which of course has both a federal and a state component, also plays a larger role in mental health substance use disorders, while Medicare plays a smaller one. And finally, private insurance plays a significantly smaller role in treating these diseases than it does in overall health care. The payer mix for mental health and substance use disorder treatment is undergoing a change as a result of the Affordable Care Act. But because these data are from 2009, they don't reflect these changes. States funnel their mental health substance use disorder dollars across many state agencies and entities. Tracking the dollars spent by these various organizations is difficult, which makes evaluating the outcome of each state's investment also very difficult. In mental health, Medicaid has been assuming a far larger role funding treatment over time, while state-local funding has been shrinking. This is a trend that has been occurring since at least 1986 and is projected to continue largely due to Medicaid expansion under the Affordable Care Act. You can also see that the role of private insurance has gradually increased. Here's a parallel chart for the payer mix in substance use disorder spending. This also shows a projected growing role for Medicaid in SUD treatment and a fairly steady one for private insurance and other state and local funding. But the big shift among these payers occurred between 1986 and 1998. Back in 1986, Medicaid played a small role in substance use disorder treatment, while private insurance and state and local funding played larger roles. This slide shows some of the factors that will influence coverage and funding for mental health and substance use disorders in the coming years. Not only will there be a shift among payer types, but more people needing treatment will be brought under an insurance umbrella, whether it be Medicaid, individual insurance through an exchange, or extended coverage on a parent's policy. Thank you very much, and I'm going to turn the floor back to Laura.
Thank you, Maria, for those comments and for those great reports. For those that are listening, you can get those reports by going to Pew's website, and Maria provided you with the links. So we're going to now move to our second speaker, Kathy Brown. I'm going to turn the floor over to you.
Okay.
And you can go to the next slide. So Missouri has been involved in trying to integrate behavioral health and primary care for about the last 10 years at least, and that's the focus of my presentation today, is on integrating behavioral health into primary care. And we've done it the other way as well, integrating primary care management into behavioral health, and I'll talk about that briefly, but I'm focusing on how we're doing behavioral health work in primary care. So in the mid-2000s, we developed two initiatives. The first one was focused on chronic care improvement, and it was really our first foray into this effort. And we used the principles of disease management, care coordination, and case management to serve patients identified through risk assessment and disease stratification. And then that following year, we developed and implemented the Behavioral Health Primary Care Integration Project to improve access to care and improve coordination of care. And it's co-located behavioral health consultants into primary care clinics, and that model is actually still occurring today in some FQHCs and community mental health centers. So that kind of paved the way and made us very excited to be involved in writing a state plan amendment, and you can go to the next slide. When the opportunity came to get into the Health Home Initiative, it seemed like a great next step for Missouri. So we debated on how to do that and decided that we really wanted to approach it from two different ways and not to try to combine these into one state plan amendment. So we developed two in 2011, and in fact we were the first to be approved in the country. So we wrote one to integrate, as the focus of it was on behavioral health, the community mental health centers, and to integrate primary care into that model. And then the second one is the one that I work with, and that's the primary care health home, and it was done to provide health home services to Missourians who are Medicaid eligible and have chronic illnesses and or mental health conditions and or substance use disorders. And you can go to the next slide. So like I said, we have two. The first one focuses on primary care and the second one on behavioral health. And the similarities and differences of the program, so we took in primary care health homes, we modified the traditional primary care model by integrating behavioral health into that through the addition of a behavioral health consultant. And then for the community mental health center healthcare homes, we added primary care management into that traditional model in the community mental health centers, and we added nurse care managers and primary care physician consultants to them. And they don't actually provide, most of them don't actually provide primary care in the community mental health centers, but they do take responsibility for the comprehensive care management and care coordination for both the mental and physical health of their participants. And you can go to the next slide. So the goals of our health home initiatives are to reduce inpatient hospitalization, readmissions, and inappropriate emergency room visits, improve coordination and transitions of care, improve clinical indicators, implement and evaluate the health home model as a way to achieve accessible, high-quality primary health care and behavioral health care, and to integrate primary care and behavioral health care, and to demonstrate cost effectiveness so that we can justify and support and sustain this model, and then support our practices by increasing resources and improving care coordination so that there can be improved quality of clinician work life and patient outcomes. And so we started these on January of 2012, and we're very pleased with how everything is going, and I want to just tell you a little bit about that. So next slide, please. So in our state plan amendment, we said that our health homes would provide 6 different types of services, and we call them touches, and they include comprehensive care management, care coordination, health promotion, comprehensive transitional care, patient and family support, and referral to community and support services. So in these, the behavioral health consultant and the nurse care manager work together with patients to create and monitor self-management goals. The BHC helps to manage the high utilizer population, and the behavioral health consultant also helps monitor and makes phone calls regarding medication adherence when we see that somebody does not have a good medication adherence rate. Then the behavioral health consultant gets involved with that, because we've found that in many of these cases, the reason someone isn't taking medication appropriately has a behavioral health component. And the BHC also helps to connect patients to ongoing behavioral health care and other services, so they're involved in that referral process as well. I wanted to share just one testimonial, if you will, that came from one of our health homes after they had been doing health home services for a while. And they said a formerly obese woman came in to complete her written care plan with the nurse care manager and the behavioral health consultant. She was post-gastric bypass and her A1C was under control, so she desired to stop smoking. So they scheduled her with her primary care physician for a Chantix prescription, and also with the behavioral health consultant for counseling regarding smoking cessation. Then she also needed dental care because her dentures were too big since her weight loss, and she was actually using toilet tissue to make the dentures fit. So she was referred to a dental clinic for an appointment to deal with this. So that's just one very brief example of how these care management services and the whole concept of the health home help to improve this person's life, and how the behavioral health consultant is involved in that process. So next slide. So to qualify to participate in the primary care health home initiative in Missouri, you have to have a combination of those conditions that you see on the screen. The diabetes is considered not only a condition but a risk factor for other conditions. So at this moment in time, it's the only condition that by itself qualifies for participation. The others, you have to have some combination of 2 or more of those. And then next slide. We are currently revising our state plan amendment. We're amending the amendment to include mental health conditions and substance use disorder, which have been all along part of our behavioral health care home qualifications, but we have not included them on the primary care side up until now. And the only mental health conditions we're adding are anxiety and depression. We know our people have severe mental illness as well, but we feel that those are more appropriately managed through one of the behavioral health care homes than the primary care. But we do want to be able to include people with anxiety and depression, and then also those with substance use disorder. And that would require that the providers that would do that would have to go through and obtain and maintain certification in order to do that. So I'm not sure exactly how many of them are going to proceed down that road, but we wanted to make it available to them if they want to. So we plan on submitting our amendment by the end of this month, and then our changes would start sometime in 2016, assuming that they get approved. Next slide, please. So in our primary care health home, we have the roles that you see on the screen there included, and the other people within an organization also participate in the initiative, but these are the ones that are funded by our health home initiative. So there's a minimal piece of a health home director. A nurse care manager is the most intensive role that we have, so there's a full-time nurse care manager for every 250 participants. Then we have the behavioral health consultant, which is either a social worker, an LCSW, or a clinical psychologist, and they have a 1 to 750 ratio, as does a care coordinator. And the physician champion is a role that we've just recently made one of our official roles, and we haven't developed a ratio for that yet. And then I also want to say that we are just now starting a pilot project to add community health workers to the Health Home Initiative. So we have 2 areas within Missouri, a rural area and an urban area, where we're implementing this project, where there would be a community support worker employed at some of the health homes who would extend the care coordination function out into the community, do home visits, or meet in some other setting in the community, help with referrals, help with barriers, whatever those are, whether they're involved with social determinants of health or whatever, so that people who are in the Health Home Initiative can better manage their conditions and achieve a better quality of life and reduce services that, and resulting Medicaid costs. And these are focused on our high utilizer populations is what we're doing here. We're hoping if these pilot projects show success, and we anticipate that they will, that we'll be able to extend community health workers throughout our Health Home Initiative when the pilot ends at the end of 2 years from now. Next slide, please. So our behavioral health consultants, what they do in the primary care setting in our health home is the BHC focuses on managing a population of patients versus providing that specialty therapy that is traditional. They are co-located and they're available for warm handoffs. That's one of the real successes of the initiative, is that if the primary care provider, the nurse care manager, or whomever determines during the course of a visit that someone could benefit from a brief intervention by a BHC, that they're there and can be introduced, and that can happen right then. The BHC supports the care team in identifying and behaviorally intervening with patients, and it's all focused on improving their physical health condition, because we know that you can't just look at somebody's physical health without looking at the behavioral factors that impact that. So the BHC meets regularly as part of the primary care health home team, and to plan treatment and to discuss cases. They exchange information with team members as just informally, and things that they have noticed or whatever. So they're just an integrated part of the team. Next slide, please. And as I mentioned before, the BHCs assist with the management of high utilizers. They provide behavioral supports to assist individuals in improving their health status excuse me, and managing chronic illnesses. just recently we started allowing the BHCs in health home provider organizations in Missouri to start billing Medicaid for health and behavior assessment and intervention services, and I'll talk more about those in another slide down the road here. They screen and evaluate individuals for mental health and substance use disorders. They conduct brief interventions for individuals with behavioral health problems, and one of the major differences between this and traditional behavioral health care is that they don't provide ongoing traditional counseling services. That's not their role. There might be other social workers in an organization that do that, and the BHCs can refer to them, or if they don't have that service available in-house, they help make sure that the person gets connected to a community mental health center or somewhere where they can receive that ongoing traditional counseling. They facilitate group classes. They assist with medication adherence or treatment plan adherence and goal setting. And then they also provide brief coaching sessions for SBIRT. And SBIRT is screening, brief intervention, referral, and treatment. And it is part of the screening process that's done for every person in primary care health homes annually. And we also do depression screening on every PCHH participant annually. So the BHC plays a big role in making sure that that screening is done, and if they need services beyond just the first screening level, they're involved in that process. And next slide, please. One of the things that makes a health home different from traditional primary care is the focus on population health management and using health information technology tools to make that happen. So health homes can get a list of all of their patients and their medication adherence levels. They can sort those lists and determine who needs immediate attention in that area. Same thing with the high utilizers. They get a monthly list showing people that have had 3 or more ER visits in a 12-month period or 2 or more hospitalizations in a 12-month period. They can determine, follow up with people, try to figure out what's happening there, and is there something they can do to intervene and impact that. We also provide daily hospitalization authorization notifications so that the health home providers know who is going to be admitted into the hospital so that they can then follow up and make sure that discharge planning is done appropriately and do a medication reconciliation and make sure the folks know how to take whatever medications might have been changed during their hospital stay. And then we also, our newest thing that we're starting to provide our health homes is a list of people who have been seen in the ER the previous day. So they can also follow up with these folks, particularly ones that they determine could have been seen in the office setting instead of the ER, and try to contact them and work with them. And the behavioral health consultant definitely gets involved in that process as well. Next slide. So as I mentioned before, the health and behavioral assessment and intervention services is a new thing that we have just started. So we have training for BHCs to get certified to provide these services, and once they're certified, they can bill for those services. Now, in order to make sure that this isn't an overlap with the payment that we receive from Medicare and Medicaid, well, excuse me, not Medicare, but from the federal and state part of Medicaid, if they're being paid 100% by the primary care health home initiative, then they can't bill for these services. But many of the behavioral health consultants, there's not enough people enrolled in their health home to justify them having a full-time behavioral health consultant, so they can provide these services during their time that they're not actually paid by the health home initiative, and that helps to supplement the payment that they get for them, and so that organizations can have these people on staff full-time. And then screening, like I said, the SBIRT, we do that on every person, and there's 3 levels of the SBIRT. There's just the brief screening. Most people turn up negative, but if they turn up positive, then they go through a second level, which is the assist. And if that level turns up positive, then the behavioral health consultant does a brief intervention to determine what next steps are needed. And the goal of SBIRT is to identify problems before they actually happen. So it's looking for people who are not yet needing substance use treatment or anything, but it's trying to identify them and head the problem off before it gets to that point. So next slide, please. So I just have a few results I want to share with you. These are from earlier in our program, and we're working now on getting our more recent results compiled, and we're going to be publishing a paper within the next few months. But you can see this shows a trend, decreasing trend for ER events that we've seen in the primary care health home. It does kind of take an interesting pattern, but if you trend it, it definitely shows a decrease. Next slide, please. And then we do have a statistician working with us, and these next few slides I'm going to show are statistically significant as far as reductions in LDL, hemoglobin A1C, and blood pressure. So this one is for A1C, so you looked at it when the person came, or the people came into the program, and then after the first year and after the second year. So we're seeing a reduction in A1C level for diabetics. Next slide, please. And the same thing with the LDL. You can see that those are decreasing with people who stay in the health home, and so it's doing what it's supposed to do, so we're very encouraged by that. Next slide, please. And the last one shows a slight reduction in blood pressure for individuals who were identified as having high blood pressure to start with. So, and we're continuing to analyze these and are still happy with the results that we're seeing. And one more slide here. The good news is that it doesn't really take much of a decrease to make a big impact. So if somebody's cholesterol, you could lower it by 10%, that means a 30% decrease in coronary heart disease. Or if somebody's blood pressure can go down just 6 millimeters, that correlates with a 16% decrease in coronary heart disease, or a 42% decrease in stroke. And then only a 1% point decrease in hemoglobin A1C equates to a 21% decrease in deaths related to diabetes, 14% decrease in heart attacks, and 37% decrease in microvascular complications. So that's one of the reasons that we're focusing on these conditions, is because you can see such a major impact just with working with people and making small inroads. So, and then the last slide is just my contact information, and I appreciate the opportunity to share all of this information with you, and I'll turn it back over to Laura.
Thank you so much, Kathy, for giving us a real nice rundown of what's happening in Missouri And we'll take questions at the end of the 3 presentations. But before we move on to Barbara, I just want to remind everyone that you can submit a question at any time by clicking on the control panel on the right side of your screen. Once you do so, enter your query in the questions box. And we have a lot of time for Q&A, so please get your questions in. So at this time, I'd like to turn it over to Barbara.
Okay, good afternoon, everyone. Again, I'm Barbara Samaglio. I'm the Deputy Commissioner at the Health Department in Vermont. Vermont operates an integrated health department, so we are both the state and local branch of public health and work closely with our health reform initiative. Next slide. So Vermont, you can change this slide. Vermont has made a commitment to a comprehensive approach to healthcare reform. And many of the things that Kathy shared about what Missouri is doing apply to Vermont as well. So there's some consistency in how we're all approaching. The goal of our efforts as the national goal is to improve population health, improve the quality of care, and lower the cost for overall care. Next slide. Because we're in the health department, our approach to our components of the overall health care initiative are to look at the whole population's health. We take a public health approach to how we do our work. We look at the data. We look at what partners we need to have involved in the initiative. We look at what policies we need to develop, program implementation with the appropriate partners, and then we evaluate the outcomes. So we hope to bring that comprehensive view to everything we do and thereby achieve measurable outcomes when we implement programs. So next slide. So with our, I'm going to speak primarily about our initiative with substance abuse treatment and increasing the access to substance abuse services. Vermont is a state that is experiencing some fairly significant opiate challenges. So I'm going to talk about how we went from knowing that to implementing programmatic interventions and then looking at how we're measuring the impact of those. So the first thing we did was look at a lot of data. You know, our rates of addiction from the National Survey on Drug Use and Health, which is all this data is available for every state through the Substance Abuse and Mental Health Services Administration. We look at our health survey data through the Youth Risk Behavior Survey, which is under CDC umbrella, and the Adult Behavior Risk Survey. And then we look at our treatment data. What's going on in our communities? Are people able to access treatment? What are the conditions they're presenting with? And we began by looking at all of that data, and I'll say a little more about that in a minute. Next slide is, this is just to show you our model. We do take a public health approach where we strive to get broad prevention services to the whole population, which focus on education, skill development, and policies in the community that support the healthy choice being the easy choice. And then we go up the pyramid, you know, with intervention programs such as screening and brief intervention, which Kathy talked about, treatment at more intensive levels as the condition becomes more severe. Next slide. So going back to how we began our initiative and the focus, we looked at the data that we had, and we saw that we had actually a pretty similar experience of people needing treatment but not receiving it as through the as for the whole United States. And you heard our first speaker talk about most people who need treatment don't know that they need it, or they don't have that awareness. And that's certainly true in Vermont. Next slide. what we were seeing at the same time, however, in our specialty substance abuse treatment programs is that the number of individuals that were coming into treatment identifying opiates as their primary problem was increasing faster than everything else. For many years, like most states, I believe, alcohol was the #1 reason people came into treatment, alcohol use disorders. But we were seeing this huge spike with opiates, and so, you know, clearly we knew we had to do some changing. Next slide. And then on top of it, we saw that we have been seeing that heroin is increasing ever more swiftly. So we started off with prescription opiates being a rising problem, and now in the last several years, if you see the blue line, it's really taking a steep upturn with heroin use. Next slide. So we looked at that data and we said, oh dear, we have a perfect storm. And we came together with our partners in our healthcare reform initiative, which in Vermont is called the Blueprint for Health. And this is the entity that, like Kathy spoke in Missouri, the health homes and all that comes with that is under our Blueprint for Health initiative. So we came together with our partners, Blueprint, our Medicaid partners, and our community partners, and we looked at a couple of realities. We had increasing rates of opiate dependence. We had inadequate network capacity in the community. We were seeing higher healthcare expenditures with these individuals coming in for specialty care. We were seeing poor outcomes and really a lack of connection to other health care, primary care. Most of the patients didn't have a physician as they were in and out of the emergency room. And then we see that our programming was very siloed, and you know, you had to go over here for this and somewhere else for that, and it wasn't contributing to a comprehensive approach that was really helping the patient get better. So next slide. Then we moved into how do we bring all the good experience we've had in the general health reform and start to look at it more particularly for these high utilizers that had a serious substance abuse problem. So the Blueprint has a model where they pay providers for implementing desired practices if they meet certain standards and if they add certain new features that are part of healthcare reform, those health home services that Kathy spoke about, they get an enhanced rate. And we're also in Vermont moving toward using accountable care organizations to manage whole populations to address the very chronic diseases that Kathy also spoke about. So we wanted to start with a policy to bring in substance abuse, looking at how do we begin to infuse screening across the board. And so SBIRT, you heard a little bit about that in Kathy's presentation. We were very fortunate to get a grant from SAMHSA again, so we've begun our work on SBIRT. We're not as far along as Missouri, but we have 10 sites now across the state that are infusing SBIRT, and it is a measure for our accountable care organization. So our intention is to spread that then across the whole medical system. Next slide. And the other, this is just a little diagram. Oops, it didn't come through 100%. Oh, here it comes. So this diagram basically shows how the Blueprint works. And I'm not going to get into all the nitty-gritty, but it basically shows a few important things. All of our insurers are part of the picture. Medicaid, the commercial insurers, and Medicare all put in resources to this model. And then certain services are fee-for-service. There is a payment for quality, as I mentioned. And then there are some additional staff that are part of these community health teams, which are new resources based on the population served in a community. So it really adds the capacity to do the population management and the specialty care management. So that's the policy level. Next slide. Then we looked at what programs we really want to focus on. Starting with prevention, we always have a base of prevention and public awareness. So that goes along with everything we do. That is not traditionally a big part of healthcare, but we're hoping that as things move along, wellness and wellness management are going to become ever more important in the behavioral health arena, because that will help us move more quickly. So we definitely, as I said, are starting with SBIRT, screening and brief intervention. Next slide. This is just a little more about SBIRT. I'm not going to go into detail about it, but I think it's fair to say that very similar to what Kathy spoke about, we have screening in primary care medical practices, in emergency departments, and in federally qualified health centers are the types of sites that we're working with. And again, creating local teams so that when people need to have that handoff to the specialty provider, that everything's structured so that they can move a person right over. Next. And then in particular, we focus on the Care Alliance for Opiate Addiction, which is our brand new, this was again done under a state plan amendment under the Affordable Care Act. This allowed us to get enhanced match from Medicaid for 8 quarters in order to begin the implementation of our new system. So the goal is to improve the direct connection between specialty care providers and primary care, and linking, beginning with assessment, referral, protocols for placing patients and managing care, and then linkage to recovery coaching. And the focus is patients with opiate dependence. Next slide. This again is a schematic that shows our state, and that we have what we call the hubs, which are placed strategically around the state. They are opiate treatment programs, which means that they are certified by the federal government and the state government to provide methadone and all levels of medication-assisted treatment to people with substance use disorders. They're led by a physician. They are medical homes. Anyone in treatment has to have a single provider, pharmacy home. They're managed by a community health team, and linked to spokes, which are primary care physicians that are placed around these hubs to all support those patients who, after beginning in the hub, can safely be transferred to primary care for ongoing treatment management. So we're really trying to create a statewide system of care for addiction treatment that has the specialty care in the hubs and then the continuing care in the physician system in the community, thereby enhancing both regular health care and specialty care. Next slide. So the system enhancements, as I said, we've increased capacity. The hubs are paid in a monthly bundled rate that includes the traditional treatment and the health home services, and that again, that's an inclusive monthly rate. You can go to the next slide. The beneficiaries get the full health home services, whether they're in an opioid treatment program or in the spoke, the office-based opioid treatment. And next slide. And this just tells you a little bit more about the model. So for every 400 patients in a hub or a specialty center, there are 6 nurses and per 400 patients. That just shows you the health staff in addition to all the specialty treatment staff. In the office-based model, There are 2 additional FTEs for a primary care practice who becomes a spoke. They get a nurse, case manager, and a master's level clinician to work with every 100 patients they have in their practice. So that really blends the traditional model with the medical home approach. Next slide. In addition to the programming that I highlighted briefly, we also recognize that a system only works if you have support surrounding it. Again, this comprehensive approach that we're trying to implement. So training is very important. We've had a focused effort to improve the primary care system's knowledge of pain management and addiction. Through our SBIRT initiative, we brought in a lot of technical assistance and development for the medical community. We've also worked in collaboration with Dartmouth College, the medical center, to develop a learning collaborative for our physicians and clinicians involved in the hub and spoke model. That involves the development of common clinical protocols and learning collaboratives that are held regionally so that the clinicians can learn from both experts and each other, and we can strengthen our network and our ability to work in a team-based model. Next slide. Finally, we know that regulation is extremely important to make sure that we have quality standards that we're holding everyone to. So we do have a regulation, a state regulation that covers anyone doing medication-assisted treatment. And again, the OTPs, the opiate treatment centers, are highly regulated already through SAMHSA. They have to be accredited. But the physicians who do this work really didn't have any special qualifications or requirements. So we developed a rule so that we are very clear what's expected. And just this year we passed also a unified pain management rule that covers you know, pain management in the primary care setting. And so the kind of things we want to make sure is that everyone's checking the prescription monitoring program so that we can ensure good opiate treatment practices. They have to have contracts with patients, you know, minimum standards for how to use urinalysis, tools like pill counts, you know, when you want to make sure that the patient's being accountable, etc. So happy to share any of the rules. They're all on our website, but if anyone has any further questions. We found that having this regulatory piece really helps us you know, build toward a high quality system. And then finally, we're looking at, next slide, what the outcomes are. And we're just beginning to gather data. And we're looking at change in attitudes and behaviors in those national surveys that I started with. So we want to see that more people are able to access treatment. We want to see that their attitudes about using drugs are changing in the right direction, etc. So we'll look at that ongoing survey data annually to see how we're doing. We want to see reduced use. We want to see, in the end, lower healthcare costs and improved patient functioning. So next slide. Our preliminary, okay, one more thing here. The number of Medicaid recipients receiving services for opioid treatment, this shows that we are improving access. So that was our first goal. If we can't do that, we really can't do much on the other one. So we are achieving that. And then next slide, approximately 70% of Medicaid recipients with an opioid dependence are receiving their treatment through this model. So we're really pleased to see the way we've been able to increase support for these patients. Next slide. And then the preliminary findings from our Department of Vermont Health Access, which is our Medicaid division, and the blueprint. We are doing a combined data analysis, and our preliminary data is showing that individuals with an opioid-dependent diagnosis receiving specialty treatment have lower medical care costs than those who are not receiving medication-assisted treatment. So we're going again in the right direction, and the longer they remain in treatment, the more we see the reduction in their non-treatment related medical costs, so things like emergency rooms and other things. Next slide. Patient functioning at hub discharge, we see an improvement of those who are in that treatment than those who leave treatment early. I am going to end quickly by just, next slide, the other things that we're doing in order to have a more comprehensive system: increasing our prevention efforts, intervening earlier in school-based and SBIRT services, really making sure that there's a robust outpatient treatment system, and continuing to strengthen our recovery services. So next slide. Consistent with what I just said, that shows you our priorities for fiscal year 16. And since this is the NCSL, our legislators are true champions. We could not have done any of this work without a partnership and support with both our administration, obviously, and our legislative leadership, because they must understand and support this for us to be successful. So last slide. Challenges, obviously, you know, we need more people to sign up for the insurance. Deductibles and premiums and co-pays are still problems, so we still need the block grant to offset and help people have access to care who, you know, might still fall through the cracks. And we need the medical community to really step up and want to work with this population. So leadership of our health commissioner has also been really critical to, you know, getting the medical community engaged. So thank you. Sorry to rush, but I wanted to make sure I gave you the whole picture. And I'll turn it back over to the moderator.
Thank you so much. I would like to thank our three speakers for their excellent presentations, and I would also like to thank the Pew Charitable Trust for their support of this program. The floor is now open for participant Q&A. As a quick reminder, to ask a question, please click on the Q&A button and type in your question. Please make sure that you ask your question to all panelists, and remember that the questions will remain anonymous. So I have a question, Barbara, I'm going to ask you first because it's a question about one of your slides. One of the participants wants to know, on your capacity payment slide, was the number 35,000 or 350,000 per 20,000 people?
Oh, yes, it, I believe it's 350,000.
Okay.
You're right. There's an error in that. That's not my slide, but I think that is correct. Yes. Needs another zero.
Thank you. So, Kathy, this question is for you. What sort of credentialing is required to become a behavioral health consultant?
You just have to either be a licensed clinical social worker or a clinical psychologist.
And on the same vein, there's a question about how are community health workers trained and what sort of credentials do they have to participate in your program?
In Missouri, we are currently developing a statewide curriculum for community health workers. The Department of Health and Senior Services is heading that up, and we're working in conjunction with them, and they are basing their curriculum on some other established curricula that they have found throughout the country, and then it's being offered at will be offered at several of the community colleges throughout the state. And So eventually, if our pilot continues and it goes, we keep this as a permanent part of the Health Home Initiative, all of the people who are community health workers would have to be certified by one of those programs or something that we would consider equivalent. For the pilot initiative, we're just people can self-declare themselves as a community health worker by either having a certification from somewhere or by having a requisite amount of experience and education. And you know, I don't have all of those details right in front of me, but since it's just a 2-year pilot, they can go through the certification process if they want to, but we're not requiring that.
Thank you. So this question is for Barbara. Within the intervention level of your program, can you expand a little bit and tell us about the services that are provided through your schools?
Oh, through the schools. We provide school-based health services. Our goal is to have a comprehensive school-based approach to health in all schools. But we give particular grants to do health education, specifically around substance abuse, skill development, and screening and referral in the schools. So we have a number of our districts, not all of them, but they get a grant, and that again comes primarily through our Substance Abuse Prevention and Treatment Block Grant. Allows us to use some of those prevention dollars in the schools.
Thank you. So this question is for both Barbara and Kathy. What resources would the speakers recommend utilizing to find out about substance abuse and opioid addiction rates in a geographic region? Barbara, you referenced the CDC. Are those surveys publicly available?
Yes, actually, I think both the CDC and SAMHSA have a lot of data available on their websites, but in particular the National Survey on Drug Use and Health, which is a SAMHSA survey, it is available on their website, and if anyone has trouble, I'm happy to try to provide some help to get there. CDC also just came out with a vital signs. They do a publication, and they just did a big publication on heroin, again available on the CDC website. But the state by state is SAMHSA.
Thank you.
Yeah.
And I don't have anything additional to add. She did a great job of outlining resources.
Thank you. So this next question is for both of you as well. There are a few questions about behavioral health workforce shortages, and so just interested in how Missouri and Vermont are staffing their programs, and how are you dealing with behavioral health workforce shortages, and do you have any words of wisdom and advice?
Well, this is Kathy, and I will just say that we did initially have concerns of being able to find either LCSWs or clinical psychologists, because a lot of our health homes are in rural areas in the state, and since a lot of them don't have enough people enrolled in their health home to justify a full-time person, we thought, oh, well, it may be difficult to find just somebody willing to do this 50% of the time or whatever. And we have actually not really encountered that specific problem. People have had to be creative. Our organizations, some of them contract with the community mental health centers in their area for pieces of behavioral health consultants' time, and otherwise, you know, we really have, we've not had anybody that has not been able to find qualified people to work in the health home. But you know, the health homes really are pretty small. We're not taking, when you look at the whole state, so we're not requiring just a ton of behavioral health consultants yet, but we have not had problems.
Well, I'll offer the other point of view. This is Barbara. Vermont's a small state, and I do a lot of work with my partners in New England, and I would say throughout New England, I know we struggle with workforce. For Vermont specifically, with the enhancements that we've done, we struggle with workforce in a couple of ways. Addiction doctors, you know, anyone who has a specialty in addiction medicine is very difficult to find. And so that's been one challenge. We've been able to interest some doctors in moving to Vermont, and that is certainly one way to deal with workforce, but also to partner with our university to try to encourage more partnership to grow, you know, these specialties. With our counselors, we use, as Missouri, licensed social workers, mental health clinicians, and we have a licensed alcohol and drug counselor profession. So any of those folks, psychologists, could all fit into our work. But we have expanded rapidly, so workforce is a challenge. So one of the things that we're trying to do is you know, definitely partner with local hospitals, local community colleges to try to figure out what's going to help locally. But it's definitely a challenge, and it's also, again, on SAMHSA from the federal government. They've identified workforce as one of the priorities for the coming year because many of the states are struggling with workforce. So, yeah.
Thank you. So this last question is for Barbara, and I'm sure that you could probably talk about this for a very long time, but I'm going to ask you to encapsulate and just share with us the highlights. How did your state get all of the payers to the table? So one of your slides mentioned that, you know, all of the payers in your states were participating in this. So can you give us a few words of wisdom on that?
I have one big word of wisdom, and that's leadership. I think this came straight from the leadership in the legislature and the governor's office. I think that health reform was identified as a top priority, and when we created as a state the structure for healthcare reform, I think there were very high-level negotiations about everybody needing to get to the table. Now, the other thing is Vermont's a small state, so what we can do in Vermont is probably not doable in California. So what we might do statewide, you know, another state would do regionally or in an urban area, you know, and I think it's really helping people see the benefit of everyone working together, especially with our high utilizers of care.
Thank you so much. That concludes the Q&A section of the webinar. Again, I'd like to thank Maria, Kathy, and Barbara, our excellent speakers on today's webinar, and all of the attendees for your time and participation in today's conference. And thanks again to the Pew Charitable Trust for their support of this program. If you can advance the slide to the resources. So these are just links to NCSL's and Pew's Charitable Trust's website. And also on the very bottom of the slide is the link to the webinar archive. And that will be available to you if you'd like to download today's presentation. Thanks once again, and have a wonderful weekend. This concludes our webinar.